What I'm going to do today is I'm going to go through everything you need to know about entering the Medicare system, how it works. Virtually everything you're going to need to know you're going to learn today in less than an hour. That's the theory, at least. Okay, so this is basically a Medicare 101. If you have questions as we go along, I gave you a sheet to write a question down there. I'm going to try to contain the questions to after the event. That way, if people have to get out of here, whatever reason, get through the material, and then we can always talk to you after. Okay, so we're going to, like I said, we're going to basically answer all the questions that you need to know. There's a bunch of stuff I'm going to go through first, however. Of course, this is my, this is great that you're here. I appreciate it. But this is an ongoing thing. We do this every month at some location around Long Island because people are turning 65 every month. And the turnouts over the years have been bigger and bigger. Years ago, we used to get 4 or 5 people. Now, during the annual enrollment, which occurs at the end of this year, you can get 200, 300 people in a room because there's so much information out there, it's confusing. So we're going to try to address those issues for you and give you a very clear understanding of the pathway into Medicare. Provided you the handbooks, and keep on to those. The most important thing about this event here is we're going to talk in generalities, things that may or may not apply to you specifically. Your situation is absolutely unique because of different reasons. So anything I talk to you about today is a general, aspects of Medicare and how it operates, but your situation will be totally different. So keep that in mind as we go along. Here's some things that you need to know about. The most important one here is that CMS, or Medicare, prohibits me from requiring you to provide contact information. However, you can provide it to me if you want me to call you. It's an important thing about the Medicare industry. We can't call you. There's a lot of times people call me up and say, how come you never called me? I can't by law. Prevented by it. It's ridiculous, but I don't know. So that's why you sign the form when you come in. If you don't want us to call you for any reason, just say, hey, don't call me. We won't. But we're here to help you, not to bother you. Okay. Let me just skip over this. This is all in your book sheet here. Here's the rules of do's and don'ts during this event. And again, I told you we're a highly regulated industry. This is the book that Medicare generates for me. You can see right here. It's just one section of a massive manual that tells me all the things I can't do. Right? So these important aspects are the things that I can't do. First, this is considered a formal event, not educational. So I can't talk to you about specific products, but I can talk to you about how products work. Got that? Not my rules. Because it's considered a sales event and not educational, we're going to be discussing specific products in the Medicare industry. I can't give you food, but I can give you coffee, which we did. Okay? Can't give you a book or a gift or a raffle. That's why I don't want to look like a cheap guy. I want you to know I can't do it. We can only discuss one product today. So for example, if you're discussing Medicare and you want to know about, I don't know, how your life insurance works, I can't talk to you about it. Even though I'm qualified, I'm going to go into that. I can only discuss Medicare today. Anything other than that, write down your question. I'm happy to talk to you offline here. There's a bunch of other rules here. The most important one here is I can't ask you questions. You have to ask me. This is nuts, right? This is the rules. And I'm going to talk in standard. This is the most important one you need to know about. I'm going to be discussing everything in what's called standardized language. I'm going to give you an example of standardized Medicare language. If the plan that you're looking at, the insurance coverage, has no premium, you may say it's free. But for me, I have to call it a zero plan premium. You got that? You see that on TV all the time. They can't say, we don't charge you anything. It's free to you. You can't say that. It's a zero plan premium. So when I use certain language, and you're like, that's stupid. Why do you just say that? This is why. I'm using standardized language required by federal law. Everybody got all that? Okay. Next. This is my resume. It's in your booklet. I'm not going to go into the details. What you need to know about me is that I've been in the business for almost 30 years. I have an LUTCF, CFP, every other piece of alphabet soup you can think behind your name. I'm licensed in property and casualty, health insurance, life insurance. I've got virtually every license in the industry. Most important thing is, though, I've been in the Medicare industry for over 29 years. I started with Mutual of Omaha back in 1989, and I've been in the Medicare industry through all of its changes and mortifications over the years. So I've seen and kind of heard everything that's been going on over those decades. I'm going to try to bring that knowledge to you and speed you through the process of learning so that you get as smart as I am, I think. Okay, here's the topics and how we're going to do it. First, I'm going to review the important changes that occurred in Medicare in 2013. There's a lot of them. I'm just going to highlight a few. They're in your book. You can read them, and if you have a question about it, I'd be happy to talk to you on the phone or come and see you about those things. Second, we're going to discuss how you enter the Medicare system, because I'm going to make the assumption that a lot of you are entering the system at age 65. You all look really young. Third, we're going to discuss the risk solutions. Risk solutions is a funny way of saying insurance solutions. Everybody, as they get into Medicare, asks about, hey, do I need Medigap insurance? Do I need Medicare Advantage insurance? How do they work? That's risk solutions. We're going to discuss those. And then fourth, as time allows, I'm going to answer any question. I'll stay here. It'll be like a Grateful Dead concert. We'll sit here all night long and discuss your questions. See, she's laughing. She's been to one, right? Yeah, right. Okay, so I'll stay as long as you need to have questions. Okay, so changes in Medicare that occurred in 2013. This is a big one because in 2013, all the healthcare reform that was going on that you saw on the TV starts to impact in 2013, and it will take effect in 2014. There's a lot of things that went on in this year that will affect you dramatically as far as your out-of-pocket costs and how you'll get your healthcare delivered. I'm going to not go through all this, but I'm going to outline some items. You can read all this, and it's very interesting. Here's the most important thing about all the healthcare changes. Prior to this year, Medicare was designed to be reactive towards your healthcare. What do I mean by that? They would wait for you to get sick. You go to your doctor and you say, oh, you have, I don't know, cancer of the colon, and then they start to treat you. All this healthcare reform that you see in the TVs and the news and all that, what they're really talking about is changing the healthcare model from being reactive to proactive. And it's going to happen in a lot of different ways, but the most important way it's going to happen is through the way doctors are paid. And the most important part of that is, as an example, prior to this healthcare reform, doctors never called you up and said, how you feeling? Or if you went into the hospital the day you got discharged, you never saw your physician again, never heard from him, other than come see me in my office, right? Healthcare reform essentially mandates that a doctor can get paid to call you up after you've been hospitalized for the first month and say, how you doing? Things okay? You feeling all right? Why don't you come to the office? No? Okay, I'll call you next week. And he'll get paid to follow up with you. More importantly, he's going to get paid to provide you a lot of preventative health care that you didn't get before, such as colonoscopies, colon rectal screenings, sonograms for aortic aneurysms. All these things that you know you should have been doing that were not covered prior to this because they were considered preventative are now covered through the healthcare system and healthcare reform. So even though you see a lot of stuff on TV where, you know, somebody says, oh, healthcare reform it's bad, it's actually good for you. Because what they're doing is they're bringing a lot of preventative healthcare to you to get things before they become serious. This is another important aspect. I'm going to read this one to you because this is going to affect you dramatically. You know, there's two healthcare systems. There's the Medicare system and there's the Medicaid system. Medicaid is for, you know, impoverished people, people who don't have resources. And for many, many years, people would be either in the Medicare, Medicaid, or what's called dual eligible in both systems because they qualify based on income. But the trend now is to unify the healthcare system, and the way they're going to do that is not only they're going to cut costs in Medicare, the federal government is going to pay 100% of the difference between what the state pays for Medicare recipients and what they would have received as a Medicare recipient. What does that mean to you? It means right now, as an example, if you see a doctor and he's seeing you as a Medicare patient, he may get paid $100 for that office visit. If you were a Medicaid patient, financially disqualified, meaning you had low income, he may only get paid $10 to see that patient. It's that dramatic. So what they're going to do is they're going to unify the system by cutting Medicare payments down and raising Medicaid payments up. So eventually you'll see those two systems that are operating unify into one huge national healthcare system. Why is that important to you? It's all about taxes, what you will pay eventually for your health care. More importantly, how your physician will be paid for your health care. His reimbursement is going to go down, and they're going to bring more people into the system. Right now, Medicare is the largest healthcare system in the country, with over 50 million people as members of it. So when you see a lot of these things that are occurring now in the healthcare system, it's all one large master plan. Hey, master plan to unify the multiplicity of healthcare systems across the board. Okay? You can read through all these, but this basically outlines how physicians are going to be paid and the arguments that occurred over the last year. We go over here. Here's an important aspect. You see all these things here? One-time wellness visits, aortic aneurysms, bone mass measurements. A lot of women go for bone mass measurements, osteoporosis, diabetic screening, glaucoma tests. All these things are new to healthcare and Medicare. These are all preventative. This is all the stuff that they're bringing into the system to be proactive, to get ahead of the curve, to find the healthcare issues that you're going to develop early on so that they don't become major issues for you later on. That's all an effort to reduce costs on an ongoing basis. Hospitals are also incentivized. They gave $850 million to hospitals to basically measure how they're delivering health care. That's all part of the how you doing phone call type stuff that they're going to be doing. So read through all this stuff. It's great information. If you have any questions as you go through it, you know, I'm always on the phone, or I can answer anything personally. So I'm going to get right into the Medicare system. All right? I don't want to spend a lot of time on the changes. You can read those. Okay. So of course, Albert Einstein always said to himself, I don't know much about history, biology, and health insurance. So we're going to try to get you up to speed, just like we got him up to speed. And of course, we have a little caption there. There we go. How do I get Medicare coverage, and what's the cost? That's really what everyone wants to know. You know, just by a brief show of hands, most everybody's coming into the Medicare system now? Yes? No? Yeah, pretty much. Okay, good. All right, so we're on the right track here. So we're going to deal with the basics of entering the Medicare system at age 65 or due to a disability. You might be 40 years old and you have Medicare. This is a picture of the signing of the Medicare bill. Does anybody recognize everybody there? Yeah. This was in 1965. Lyndon Johnson signed Medicare into law. But do you know who this guy right here is? He's the first Medicare recipient ever. He's got the #1 card. Anybody recognize that guy? No. This is Harry Truman. Right. Harry Truman was actually the guy who started the initiative to bring Medicare into the U.S. government system. Medicare has been a long time coming. He actually brought it into the system. It was Johnson who signed it. So that's an interesting little factoid that you can bring up at your next, cocktail party. Hey, do you know? Harry Truman was the first Medicare recipient. Okay. Medicare has 4 parts now. Prior to that, when Johnson signed it, there was 2. Part A, Part B. We all know this, right? But now there's 4 parts. The first part is Part A, hospital insurance. Only hospitals. It's a government-run program. Second part is Part B. That's the physician side of the equation. Anything outside of the hospital, laboratories, testing, doctor visits. That's a government-run program. So far, it's all government-run, right? Part C, this is new. Part C is run by commercial insurance companies. We're going to address this issue right here. But when you say I'm in Medicare, you're talking about Part A and Part B. When you talk about I have Medicare coverage, you might be in a Part C. All right? When someone says Part C, what they're really talking about is the common vernacular is Medicare Advantage. Okay? And of course, there's Part D. Everybody knows that as prescription drug coverage. So the 4 parts of Medicare is A, B, government-run side, C, D, commercial or insurance company-run side. When these came into law through the Affordable Care Act, what the government essentially did was say we're going to outsource the administration of a government program to commercial insurance carriers. This part here, we're going to go into detail about because it's very important you know about it. Because it could save you a lot of money, it could deliver better health care for you, or you may want to stay in these 2 programs. So it's very important to understand what this one is here. You're going to hear a lot about it. Okay. First, we've got to know how we get coverage. So Part A, getting the coverage. Most individuals get Part A coverage because they paid Medicare taxes while they were working. Decline. Sorry about that. So while you were working all your adult life, you were paying Medicare taxes, the FICA tax on your payroll, right? You all remember seeing that in a W-2 check, right? That means that you were funding for your entire working life your Part A hospital coverage through your payroll taxes. If you were self-employed, you did it through your self-employed taxes. But you paid for your Part A your entire life. That's why it's not a government program, it's an entitlement. You paid for it. Got that? So when they say they're going to take it away from you, or reduce, they're taking your money away from you that you paid for it, right? To be eligible, you had to be eligible for premium-free Part A, you had to work 40 quarters or 10 years and pay the minimum wage, okay? It's that simple. As long as you work 10 years or 40 quarters, paid your FICA tax, you're going to get Part A when you qualify at 65. Let's skip over this. Part A coverage includes your semi-private room and board, operating rooms, intensive care units, inpatient laboratory x-rays, nursing meals, anything to do in the hospital is your Part A coverage. So as you get to your 65th birthday, you will get Part A for 0 premium. But here, Medicare calls it premium free. Okay? Premium free Part A, you'll get it when you turn 65. Part A coverage will begin on the first day of the month that you turn 65. So if you're turning 65 on July 3rd, your effective date will be July 1. If you're turning 65 on August 28th, your effective date will be August 1. Here's a little twist. If anybody's born on the first day of the month, it'll be the month prior. So if you're born on July 1st, your effective date will be June 1. All right? We got that? Anybody turning birthday on the 1st? You don't have to raise your hand. Just know that it's going to be the month before. Other than that, it's always the first day of the month in which you turn 65. This is what it costs you for Part A through Medicare. In 2013, your premium will be 0, and that's why they call it premium free. You can buy Part A if you didn't have 40 quarters of work. It's about $450 a month. All right? But most of everybody in the United States has worked at least 10 years, paid Medicare taxes to get it for a 0 premium. The important thing about Part A is that you have a deductible when you go into the hospital. So when you enter the hospital and you're covered by Part A, your exposure is $1,184 this year the minute they admit you. That's the first most important thing that you need to know about your Part A coverage. $1,184 deductible the day you enter the hospital. If you're there any longer than 60 days, you start paying $296 a day along with Medicare. And then if you're there from 90 days plus, it's $592. So, to put it all in a nutshell, if you go into the hospital and you just have regular Part A of Medicare only, you're going to be exposed to a potential liability of over $45,000 with an extended health care stay of more than 90 days. Most people think, hey, I got great coverage, I got Medicare Part A. It is great coverage, other than the fact that you have these deductibles and co-insurance if you have prolonged health care stays. Now, I can tell you, my father was in the hospital for 7 months. If he didn't have any health insurance along with Medicare, he would have had to come up with 45 grand. But because he had health care insurance, he didn't have to pay anything. I'm going to show you how that works. But this is important. Part A is not complete coverage. That's what I'm trying to illustrate for you. Medicare Part B, that's an entitlement as well. You pay for it. But this, you pay for as you get into it. You don't pay for Part B prior to that. So when you turn 65 and you enter the health care system of Medicare, you'll start to be billed $104.90 a month, every month. So, you turn 65 in July, you start collecting your Social Security, and then they'll deduct $104.90 as your Part B premium. So Part B you pay for as you use it. Part A you pay for before. Okay, ever got that? You could potentially pay more than $104 based on your annual income. If your annual income is above 85 grand, they're going to charge you additional money over the 104. So if you're in a retirement, you're making, I don't know, $132,000 a year, you'll pay more than $104, and they'll tell you, they'll bill you for it, an excess premium. Okay. So a person age 65 or over who is not entitled to premium-free Part A can pay, and Part B, they'll get it along with it. So if anybody has not worked 10 years or is not a U.S. citizen, you can buy into the system as long as you've been here for at least 5 years. Okay. I'm going to skip over this. Part B coverages. This is what Part B covers for you. Physicians, ambulance, blood, diagnostic, durable medical equipment, emergency rooms, all those preventative services that we talked about before that are new to the healthcare system, they're all covered by your Part B doctor. What is not covered by Part B is generally what most people look for in a Part C Medicare Advantage plan, which includes dental, vision, some form of extended health care in home, like home health care aids, transportation, all the things that you think you might want generally are going to be covered through a Part C, and that's what people look at when they look at Medicare Advantage plans over regular Medicare. Skip this here. Part B is costs. Part B costs you $105 roughly a month, so it's a $1,258 known expense that you'll pay every year if you join the Medicare system, which you should. That's, I'm going to call it very inexpensive insurance. To pay $1,200 a year to have full health care, not bad. You have a deductible of $147 that is implied or incurred from January 1 throughout the entire year. So the first health care bill you get in January 1st of that year, first $147 you pay. That's your deductible. Here's the most important part about Part B coverage that you need to know. It's only 80% coverage forever. So if you had a $100,000 claim and it covers it at 80%, you would owe $20,000. It's unlimited liability. So your total expenses are uncalculable in your healthcare realm considering Part B services, because if you had $1 million claim and had no other coverage than Medicare Part A and B, you'd be on the hook for $200,000. So that's the important aspect of Part B. It's unlimited liability. But for sure, you're going to pay this and this combined $1,408 a year. It works out to exactly $117.15 a month. That's your known cost or premium for Medicare Part B, including your deductible. Here's an important factoid that we need to put in our head. When you use the word premium, premium by definition is a known loss. You've got to pay it. So Part B has a known premium or known loss of $1,408 a year, plus an unknown or unlimited liability of 20%. Okay? So if you had just Part A and B, we know there's some exposures there with deductibles and co-insurance and premiums. How do you get into Medicare? It's very simple. Most individuals are going to enter through what's called an IEP. A lot of acronyms in Medicare. It's like being in the military. They like to crunch everything down into letters. An IEP stands for your initial enrollment period. So when you're turning 65, this is an important calculation for anybody turning 65, you're going to be entering into what's called your initial enrollment period 90 days prior to the month of your birth. So to put that into real time, let's say you were born on June 15th. You become eligible to enroll in Medicare from March 1st through to June 1, the month of June, and 90 days after that, July, August, September. So you have a 7-month window in which you enroll in Part B of Medicare. Everybody got that? That's really important. These are important dates. So all you got to do is take the month of your birth, go back 90 days, and go forward 90 days, and that is your window of opportunity to enroll in your Part B, your initial enrollment period. Why is that important? Because you can't enroll early. You can't get things done too soon. But most importantly, if you don't enroll during your initial enrollment period, you may be disqualified for enrollment until the next general enrollment period, and you could have a significant gap in coverage. All right? Agree with me on that one? That's important. We're going to figure out how that works for you in a minute. Let's skip over that. Here it is in the graphical form. IEP starts 3 months before the month of your birth. Then you go into the month of your birth. All right? This is the month you turn 65. And then there's 3 months after. Now, why is this important? Let's say this is June, right? You don't sign up for your Part B. You wait till June, July. You wait till August. You can sign up and not be disqualified. But then you wait till September, and then finally realize, oh, I got to enroll in Part B in October. Because October falls outside of your initial enrollment period, you now have to wait all the way to January to enroll, and you won't become effective until July of the following year. Follow that? That's like a whole year of no coverage. So that's why this whole cycle here is very important to understand. 3 months before, the month of, and 3 months after is your initial enrollment period. You need to take action. The general enrollment period starts this way. It starts January 1 through March 31. That's if you missed your initial enrollment period, you enter the general. These are the months that you can enroll, and this is the month to become effective. That's a 7-month gap. So it's very important. You don't want to enroll during a general enrollment period. Now, why does that happen to some people? Because they turn 65, their employer says, hey, you have health care, we'll give you COBRA. They take the COBRA lasts 18 months. Because it's 18 months, it's outside of their initial enrollment period, and they disqualify themselves from entering Medicare until the general enrollment period in January. Follow? So that's why if you're retiring from an employer and you're thinking about taking your COBRA, you may want to not take it. You may want to just enroll in Medicare immediately, because you could potentially disqualify yourself from getting into Medicare and create a gap of coverage. Agree with that? Skip over that here. If you worked and you became disabled, you'd be in a special enrollment period. You can enter in any time that you want under a special enrollment period. Special enrollment periods occur, for example, if I get disabled, let's say I'm in a car accident and I break my back, I can't work anymore, I go on to Social Security Disability for 24 months, and the 25th month I become eligible for Medicare. It's considered a special enrollment. I get in like that. Or, I was working till age 70. None of this is not going to apply to anybody here, I'm sure, but you work till age 70, you decide you're going to retire, you retire. Because you missed your initial enrollment period of turning age 65, you enter a special enrollment period in like that. So there's lots of opportunities to get into Medicare, but it's all about the timing and knowing when you need to apply. If you miss your application date, it could cause a problem for you by creating gaps in coverage. Okay? Now we're going to talk about Part C. What is Part C? Part C is something new. It's only been around for about 7 or 8 years. It's called Medicare Advantage. It was brought into a being through the Affordable Care Act, and it's multiple remanifestations as they kept tweaking it. What is Medicare Advantage plans? Medicare Advantage is essentially an attempt by the Medicare system to do exactly what you do every day in your risk analysis. Like, it's the same reason you bought homeowners insurance and car insurance, why you look at health insurance and life insurance. What you're trying to do is transfer the risk from you to an insurance carrier for a known loss that we define as premium. So, let's put that into practical application for you. You bought a house, you paid, I don't know, let's pick a number, $500,000 for the house. It's a big investment for you. So you immediately go out and say, listen, if it burns to the ground, I want to make sure that I get the $500,000 to rebuild it. So you find an insurance carrier and you pay an annual premium, $1,200, whatever it happens to be, and you avoid the risk associated with the house burning down. You paid a premium. So now, let's translate that into Medicare for you. I'm the Medicare system. You're on Medicare. You get sick. I have to pay 80% of your bill. For whatever it is. If it's $1 million, I owe $800,000. If it's $100,000, I owe $80,000. I insure you. I own the risk. Medicare Advantage is an attempt by the Medicare system to transfer the risk that you pose to them to an insurance carrier for a known loss or a premium. How do they do that? Well, essentially, they combine your hospital, your doctor, and your prescription drugs into one policy or one plan for you, and they get a commercial insurance carrier to accept the risk for a payment of a premium. Pretty simple idea, right? Why does the insurance carriers take on that risk? Because that's their business. They're in the business of risk assessment. Now, the premium that Medicare is going to pay the insurance carrier is based on what's called a regional benchmark rate. How do they determine that? They take every Medicare beneficiary in this county, Suffolk County, and they take all their claims and they put them into a big bucket, mix it around, and they spread it out amongst everybody. And they calculate that it costs approximately $1,000 a month for every Medicare beneficiary, regardless of whether you use the plan or not. So if you're on a Medicare and you have no claims this month, you cost them $1,000. If you had a claim of $100,000, as far as they're concerned, you cost $1,000 because they took the other $99,000 and spread it out amongst everybody else. Everybody follow that? So now they go to a commercial insurance carrier and they say, listen, you're charging for supplemental insurance. What's your premium? It's going to average around $300 a month for an insurance carrier in this area. Now they say to the insurance carrier, listen, we'll pay you $1,000 a month, almost 3 times what they're making in selling regular insurance. All you have to do is take on the same risk, but instead of the 20% that you have to pay, just pay 100% of it. Insurance carriers love that because essentially, if you're an insurance carrier, you can't lose money by law. Insurance carriers can't run in the red. They have to run in the black. Follow that? Because if the state allowed them to lose money every year, they go out of business, and then you'd be going to the state to pay your claims. So insurance carriers, it doesn't matter for them. They'll just take the money, assess the risk, and they'll be profitable. So they combine your hospital and your doctor and your prescription drug into one plan called the Medicare Advantage Plan. How do they incentivize you to join their plan? Well, they create these things called preferred provider networks, PPOs, private fee-for-service plans, medical savings accounts. And they come out into the marketplace and say, listen, you're going to pay $105 for your Medicare Part B and nothing for your Part A. We all know that, right? Right. And you need to get some kind of supplemental insurance on the back end of that to cover the deductible and the co-insurance that we discussed. So you'll go out to, I don't know, some carrier, they'll charge you $300 a month. You'll have a known cost of $3,600 a year. So you think, wow, $3,600 a year, I could do something with that money other than pay insurance premium, because no one likes to pay premium. Not even me, I'm in the business, right? So they'll come out with a plan, they'll say, listen, join our HMO Medicare Advantage Plan, and we'll provide all the same services and benefits as original Medicare, but we'll do it for $40 a month. So they incentivize you by saying the costs are lower and we still deliver all the same services and benefits as original Medicare. So you would think, that's a pretty good deal, I'll pay $40 for that and get all the same services. But what they don't tell you is that these plans can deliver all the same services as original Medicare, Part A and B, but in any way they want, not just like Medicare would. So as an example, if you join an HMO, which there are a lot of them in the Long Island area, you can only see doctors in their system, not any doctor. If you join an HMO, you may have to make a co-payment of $500 every time you go to the hospital, per cause. Whereas every time you go in. Follow that? So there's a lot of things you need to know about how these plans operate, such as, what is a PPO? PPO is a preferred provider organization. You can only use doctors in that system. If you go out of their system, you'll just pay a lot more to do it. If you join an HMO is a closed loop. You can only use those doctors. If you use any doctor not in their system, you have no coverage. Private fee-for-service plans don't really exist here. And MSAs are the other types of plans that we, as an organization, prefer because they allow you to see any doctor, any hospital, anywhere at any time, which is what everybody wants, right? When you have a serious condition, you want to be able to go to the best doctor in the world. If you had an HMO and that doctor doesn't participate, you can't see them. So it's important you understand that Medicare Advantage plans have restrictions on them that you need to be fully informed and aware of. Now, how do they get you to come into these plans? Well, they offer you things like health club membership, transportation, dental, and hearing services. But they're very de minimis. For example, most plans that offer dental only offer cleanings. Nothing like that. If you have a cavity or a root canal, no coverage for that. Even though they said, hey, you have dental, if you don't read the fine print, you'll find out later that you don't really have dental, you have a cleaning service. Hearing, they'll give you one hearing exam per year, that kind of stuff. These things are not covered by Medicare. Medicare doesn't cover health club membership, doesn't cover vision, doesn't cover dental, any of that stuff. But these plans up here, these Medicare Advantage plans, say, join our plan and we'll give these things to you. So that's how they incentivize you. Plus they say our premiums are substantially lower. Next. So how does it work? Part C is a private insurance contract with Medicare that provides all the same benefits as original Medicare for a monthly payment called the regional benchmark rate. That's that $1,000 a month. So if you join a plan, that plan's going to get $1,000 a month from Medicare instead of whatever you're paying for your supplemental, which is maybe $300 at the most. They attract you to join the plan. The carriers offer incentives like lower premiums, co-payments, and over-the-counter drug benefits, which is like aspirin and Bengay. And some Medicare essentially buys a policy to insure the risk of the Medicare beneficiary. When you join that Medicare Advantage plan, what you've done is you essentially transferred the risk from Medicare to an insurance carrier. Medicare pays a premium, a known loss, and they eliminated the risk from themselves. Follow that? That's really important to know because that's what incentivizes the insurance carriers to come into the system. But that's what incentivizes Medicare to say, hey, maybe you might want to consider a Medicare Advantage plan. These all have restrictions and limitations, but mostly it revolves around the network. You can't use anybody you want in a Medicare Advantage plan if it's an HMO or a PPO. Anytime you hear those terms, think restriction. Part D, that's your drug plan. Part D drug plans, you get them in two ways. You get it in a standalone benefit. It's commonly referred to as a PDP, or a prescription drug benefit. Or you get it as part of your Medicare Advantage plan, which is called an MAPD, Medicare Advantage Prescription Drug. That's the most common animal that exists in this area. Most plans are offering MAPD formats. But if you get a plan that doesn't have drug coverage, you have to buy a prescription drug plan as part of your overall package. Right? Let's go there. Now, prescription drug plans, although it's the simplest thing, it's just one product we're talking about, prescription drugs, it is, excuse my French here, it is ridiculously complicated. Am I right? It's complicated. They make it so difficult to understand. It's ridiculous, and that's why that guy's crying here. Here, I'm going to break it down and make it very simple for you. When you join a prescription drug plan, the insurance companies have the latitude to mix it up and offer all different variations, so there's no standardization of a prescription drug plan. But Medicare has a standard plan format that they have to meet at a minimum. And this is what this is. This is not a prescription drug plan offered in the marketplace. This is Medicare's standard format. So if I'm a prescription drug provider, I can take this format and tweak it any way I want to make myself different from my competitors. But in, but in the end, it's gonna be based on this format. Where'd I go, Brandon? Here we go.
One more.
Okay. Here's the basic format of prescription drug. First, you have a $325 deductible that you pay in the calendar year first before any benefit is paid. That's the first thing. Some carriers eliminate it. Some say no deductible. They eat that for you because that makes them look better. Some say, okay, we impose it and then we'll cover you. The second part, this is where they get a little fancy. You pay 25% co-payment for the first 2,970 of prescription drugs you buy. So let's just break that to $1. You bought a drug that was $1. Under the federal guideline, you have to pay 25 cents. The insurance carrier covers 75 cents of that dollar. With me so far? What most prescription drug plans do, however, is they say, no 25%, we're going to make it a co-payment. $5 for generics, $25 for brand names, $50 for prescriptions that are considered specialty, and 33% for specialty drugs, like LSD or whatever they're offering. So here, as long as their copayment is considered 25% of the prescription drug cost, they can twist it to make themselves look different than everybody else. Most plans offer a copayment, not a percentage. After you spend this amount of money, you're going to enter into what's called the infamous donut hole. Everybody heard that term, the donut hole? The donut hole is essentially where, after your prescription drug coverage has exceeded $2,970 plus the $325 deductible, you're on your own for the next $3,682 worth of drugs. That's on you. That's the hole, the gap. You're shaking your head like, she's been through this. Then, once you spend the combined amount of this, this, and this, you hit the catastrophic level, and the government kicks back in, and the plan starts to pay everything for you under this format, 5% co-insurance for the remainder of the year. So you have to go through a lot of prescriptions to hit this second phase. Most people don't realize, but really your prescription drug coverage when you buy a Part D, if you're a moderate medication user, you get about $3,000 worth of prescription coverage, and after that, you're on your own. So what the government did is they came out with some fuzzy math, and I'm going to show you that in a second. But no matter what prescription drug plan you get, no matter how you twist it around, this is the mathematics of how it works. Deductible, co-insurance phase, donut hole, total out of pocket $47.50, and then you're covered at 5% from then on out forever for the remainder of the year. Y'all get that? This is confusing stuff. Okay? But there's a lot of prescription drug plans. There's tons of them around. So the most important thing about prescription drug, forget all this monkey business right now. When you buy a prescription drug plan, if your medications that you're currently taking are not in it, it's not for you. Because unless your prescription drug is listed in the Medicare's formulary, you have no coverage for it. So let's say you have hypertension, you're taking Toprol, and you go to look at a prescription drug plan because it's got a low premium, maybe 18 bucks a month, but it doesn't cover Toprol. Why even consider it? It doesn't cover your drug. You have no coverage for it. Follow me? So when you pick a prescription drug plan, it has to have your medication in it or it's useless to you. All this other stuff doesn't mean anything. Because if you have no coverage, what do you care? Right? Drug plans are picked because it covers the drugs that you have. Right? Now, companies in the drug business that make prescription drug plans design their plans in 3 different ways: basic, enhanced, and expanded. If you're taking a lot of medications, you want to have an expanded plan because it covers virtually all drugs. If you take no medication, you want to take a basic plan because it doesn't cover anything, you don't need it anyway. You follow me? That's how drug plans work. Next. So here's some fuzzy math because everybody's complaining about that donut hole thing. When it first came out, everybody's like, I'm hitting my donut hole. I have no coverage anymore from the prescription drug plan. So what they did is they passed a law that says when you enter into the donut hole under your prescription drug plan, if you spend $1 for a prescription to kind of get through that donut hole where they accumulate those dollars before you get to catastrophic coverage, you spend $1, you'll only spend 79 cents of it, but they'll credit $1 against the donut hole's accumulated amount. What does that mean? It means, let's say I go buy a $10 drug. I'm going to get $10 credited towards the amount I have to go through the donut hole with, but I'll only have to give the drug at $7.90 for it. Well, that's how the government does. They gave you fantasy money to get through it. And as time goes on, it keeps going down, where you'll give less and less, and they'll credit you more and more until by 2020, that same $10 medication, you'll walk in, you'll only give them $2.50, which is 25%, just like the formulary said. You'll pay $2.50, but they'll credit you $10 against the donut hole. So you'll get through it with funny money, not real money, but you'll get through it because they credit you this funny money to get you through. So in the end, you only spend 25 cents on the dollar by 2020 if we all live that long. Go up, we'll get through our donut hole. Okay? See how confusing this gets? It's ridiculous, right? this is like government mathematics. There's no money involved, but it's all about money. Okay. Here's the Part D rules. If you're single or married and you earn these particular amounts, this is your premium in addition to any Part D. So let's say you found a Part D plan and it was, I don't know, pick a number, $40 a month, but you earned $107 that year, you'd have to add $29.90 to it. Because if you make more, you should pay more, right? So this is the graduated amount of additional premiums based on your income that they will add to your Part D premium. It's the same formulary kind of that they use for your Part B, where it's $104, but if you make more than a certain amount, they just add more on, because you can afford more, all right? So you need to know how to control this. So what you do is you look into like extra help through the state of New York, pharmacy assistance programs, we have those. If you're taking specialty medications like your diabetes and things of that nature, you get direct programs with drug manufacturers where they'll actually give you the medication at very low cost. It's not part of your Part D program, but it's a way to contain your drug costs through all these secondary types of systems that are existing out there. And we can show you how they work, and if you need them, we'll get you there. In fact, we have a connection with a diabetes program. If anyone's diabetic, we can help you with that. Okay, so Medicare insurance, of course, does this look right? Of course, does it look right? Maybe you need some help making the right choice. So what I did is we're going to analyze Part A, Part B, Part C, Medicare Advantage, and Part D drug plans, and figure out how to insure the risk to eliminate Part A deductible, Part B co-insurance to 20%. We're going to figure out which plan might work best for you. Again, everybody's different. Everybody has different desires and needs. But when you think about it, understanding the relationship between the premium and the true cost is the key component in making a coverage decision. Because in the end, insurance is a mathematical equation. No matter what you're told or whoever tells it to you, insurance is pure math. How much premium do I pay? How much benefit do I get out? And what's my best advantage as far as coverage goes? So, you gotta understand your premium, how your co-pays and deductibles interplay with that. That creates your true out-of-pocket cost, right? Here's the definitions we need to know to understand this relationship. Premium is a known loss to avoid an unknown risk. Premium, pay so much, I don't have to worry about any risk, no matter how catastrophic it is. A co-payment is a payment defined by the insurance policy and is paid by you, the insured, each time a service is delivered. And the deductible, which is, everybody knows that word, deductible is your retained risk. That's what you take on before the insurance carrier has to step in. So don't confuse co-pays with deductibles. They're totally different things. Co-pay, you're always going to pay it. Deductible is what you pay before the insurance carrier needs to step in to contain your risk. So the first way we contain our risk, this is the most common. Jesus Christ had a Medicare supplemental, by the way. He was the first, him and Harry Truman. Okay? Medicare supplements are the original risk avoidance technique in Medicare. When Medicare came out in 1965, insurance companies looked at it and say, wait a minute, we can wrap around that insurance and provide supplemental coverage to cover everything that Medicare does not cover, such as the deductible and the co-insurance that Medicare imposes on you. So they came out with supplementals, and there's lots of them out there. But what I'm going to do is I'm going to focus on one plan. There are all standard plans in supplemental insurance. What happened is back in 1998, the National Insurance Commissioners standardized or made the same supplemental coverage from every single carrier. So if you bought a supplemental today, you can go to 15 different insurance carriers, and if you all purchase the plan, it's exactly the same benefit from every carrier. There's no difference. So when you say I'm going to shop around for supplemental insurance, there's no point. Because if you go to company A, B, and C and you ask for the same plan, it's the same benefit. There's no difference whatsoever. It's standard. We got that? So, when we're looking at supplemental, they're all alphabetically listed. I'm going to focus on what's called a Plan F. A Plan F covers 100% of all your Medicare exposure. There's no risk to you at all other than your premium. Here's how it works. If you bought a Plan F, the standard rate in New York State, Suffolk County right here is $257 a month. That's the lowest cost Plan F that you can get. There is nothing cheaper in the entire marketplace. That means if you want to shift the risk to a Medicare supplemental of your deductible and co-insurance on Medicare, you have a known loss, a premium of $3,072. You have to buy a Part D drug plan, but you have to do it because otherwise you're going to pay a penalty to Medicare. The average cost is about $41.60. That's another $500 a year. Most people want dental and vision added to it because they need the coverage. It's popular today. So you kind of add that in there. So if we went this supplemental route, why do we do the supplemental insurance route? Because we want to have Medicare remain the primary insurance carrier for us. We want to stay with original Medicare, that's the term, original Medicare, Part A and B, and we want the supplement to wrap around that and cover everything that isn't covered by Medicare. We'll have a known loss every month of $344 a month on average. That's the premium you're going to pay. Now, if you're healthy and you have no health care costs, like go to the doctor once a year, you're spending $4,136 to see your doctor every year, for sure. If you're really ill and you see the doctor every month, you're spending $4,136 a year. It doesn't matter. That's your known loss. But everything's covered at 100% thereafter. That's supplemental. Okay, everybody got that? Next. And here are the standard supplemental plans. You can see they're all alphabetically listed. Plan A, B, C, D, and so forth, all the way up to Plan N. The one that I focus on is right here, Plan F. Why? Because all these other plans don't cover everything at 100%. There's something less than that. So, Plan F is really the plan you want to have in supplemental insurance. Anything less than a Plan F, you're getting less coverage. You're paying about the same but getting less. Go back. You could go to a Plan N. A Plan N behaves like a Plan F, but it has the features that a lot of people look for because it has a co-payment to see your doctor. It has a co-payment to go to the emergency room. It feels, smells, and tastes like the original major medical insurance that you had when you were working, right? You went to Dr. Smith, you paid him $20, it's all covered. It kind of smells and tastes like that. It only costs $161, but it doesn't cover deductibles on Part B. It doesn't cover excess charge. It doesn't cover everything that this plan covers. So if you want to go the supplemental route, you should look at all these, but I'm going to tell you, you're going to end up with a Plan F because it's 100% coverage all the time. Okay? That's supplemental insurance. Now, we're going to talk about Medicare Advantage PPO plans. What is a PPO? It is a preferred provider organization. It delivers all the same benefits, rights, and privileges as original Medicare. However, you have to stay in the network of doctors that belong to that system. The reason why people choose PPOs is because it lets you go out of their system, but you pay a higher co-payment, you pay a higher deductible, you pay a financial penalty to not stay in their system. The way they entice you, however, to come into these PPOs is they offer low premiums. The average is about $38, $40 a month. So when you're shopping, you know, anything you buy, you get three major factors, right? Lowest potential price, highest potential quality, best level of service, but you never get all three at the same time, right? You can't get a Mercedes-Benz on a Volkswagen price, right? So here they're saying, hey, our price is the lowest, but you give up service because you can't see any doctor you want. You have to stay in their system to get there. They offer you the Part D at no cost. So again, that's another thing that, hey, it's an incentive, giving you drugs. You throw dental and vision in there. Here's the important thing. They cap your out-of-pocket maximum, or how much you could spend in any calendar year, at $4,500. How do they do that? They say every time you see the doctor, you only have to pay $20. But if you saw the doctor 3 times this week, you have to pay $60. And that keeps adding up and adding up and adding up. So you could actually end up between hospital, doctors, emergency room visits, laboratory visits, annual physicals, all that. You could actually spend $4,500 under a PPO, Medicare Advantage plan. That would be your out-of-pocket maximum. So if that's the case, we know what about a supplemental. Let's go back there as an example. With a smiley face. With a supplemental, my out-of-pocket cost is my premium. That's my no loss. It's only $4,100. And I can see any doctor, any hospital, anywhere, at any time. No restrictions whatsoever. Let's go back through here. Smiley face. Here, because you add the premium and the out-of-pocket, you could end up spending $5,316 in a calendar year. That's more than a supplement, and you only can use doctors in their system to get coverage. So that's why it's important to understand the relationship between premium, co-payments, and deductibles, because if you have a bad year, let's say you have a $500,000 claim, happens all the time, bypass, whatever, even though you paid a low premium, you can actually spend more. Follow that? So Medicare Advantage is, they're like wolves in sheep's clothing, HMOs are even more restricted. It's the same thing, but what they do is they basically give you the Part D, the dental, and all that stuff, and they say your out-of-pocket maximum is $3,400, not $45. But because it's HMO, what? Okay, thank you. HMOs are highly restricted. You cannot leave their network. So as an example, let's say you get diagnosed with, I don't know, Kaposi sarcoma, some kind of skin cancer. You want to go to Sloan Kettering. Sloan Kettering doesn't participate in an HMO. They don't participate in anything. So if you say, I want to go see my doctor at Sloan, the HMO that you're belonging to is going to say, knock yourself out, but you're paying for it. We're not covering that. This is not an HMO providing member. So HMOs incentivize you by giving you a low out-of-pocket and restrict you in the network only. But here's the important thing about an HMO. If your doctors, every one of them is part of the HMO, what do you care it's an HMO? They're in the network, that's great, because you have a low out-of-pocket and you're paying a low premium, right? So when you're thinking about restrictive networks, as long as every physician you're ever going to see is in that network, great deal. If you're going to see a doctor who's not in the network, it could be a problem. Very important to consider that aspect of these types of Medicare Advantage plans. By the way, I'm not an advocate, or a, what's the word? What's the opposite? What's the antonym for an advocate? I don't know. Whatever it is. I'm neither for or against any of these things. I just want you to be fully informed.
Party pooper.
Party pooper. Right? Thank you. Medical savings accounts. Medical savings accounts are what we as an organization tend to prefer. Why? Medical savings accounts give you something that other types of Medicare Advantage plans cannot deliver. First and foremost, their premium is a big fat zero. That's by federal law. It's not because the carrier wants to do it. That's by federal law. They cannot charge you a premium. You have to buy a Part D with them because they are not MAPDs. They are simply MAs, or Medicare Advantage plans. So you have to add a prescription drug plan to it. You can add dental and vision. And most importantly, your maximum out-of-pocket is $1,750, the lowest in the industry. In addition to that, medical savings accounts, you can see any doctor, any hospital, anywhere, at any time. What does that sound like? I can't say it. You have to say it.
Good.
Well, besides that, it behaves like the first type of plan we're discussing, where under a Medicare supplement, it's any doctor, any hospital, anywhere, at any time. This is what everybody wants. Medical savings accounts, there's no network. Any doctor, any hospital, anywhere, at any time. These plans here, however, are considered high deductible health plans. They're very unusual. We're the only underwriting group in all of Nassau and Suffolk County who has them. But here's how it illustrates out for you. First, on January 1, Medicare will deposit into a checking account for you $2,500 in cash. January 1, you get a checking account, you have that money deposited. You enroll anytime during the year, it's a little bit less based on how many months are left in the year. So if you come in June, you get half that money. Follow that? Not that work. You use that money in that account to pay for Medicare covered expenses while you meet your deductible, and your deductible is $42.50. So under a medical savings account format, you have a high deductible of $42.50. You get $2,500 in cash from Medicare to spend on your health care, which gives you the net spread of how much? $1,750. Your $1 coverage starts from the first $2,500. So let's say it's January 1, you go to see your doctor, Dr. Smith, and he charges you $100, and that's the Medicare approved amount. You write a check out of your medical savings account, $100, you pay him, done, claim over. This goes down by the $100 you just paid him. You keep doing that until you go through $2,500. Once you go through the $2,500, the next $1,750 you pay. And then after that, the plan pays 100% of all your Part A and Part B expenses for the remainder of the year, unlimited. Why are MSAs, in my opinion, better than anything you can get? No restrictions of networks. Any doctor, any hospital, anywhere, at any time. Low premium, 0. Can't get any lower than that other than we give you money back, which we do. Give you $2,500 bucks. You can see any doctor you want, and there's no restrictions. What's better than that? This is the best kind of money because it's free money. We're giving you money to take care of yourself for preventative as well as restorative care. Use it to see your doctor for a health care checkup. Use it for your doctor because you had a cold. Whatever it happens to be, you're fully covered. So when you think about cover solutions for risk associated with Part A and Part B and prescription drugs, this is all there is. For Part A, you have deductibles and coinsurance, which is your risk. You can either get a supplement or a Part C, which is a Medicare Advantage plan. The only question is what kind of Medicare Advantage plan. An HMO with restrictions, PPO with networks, or MSAs. See any doctor you want. For your Part B deductible and coinsurance, it's the same thing. You get a supplement or you get Part C. And for your prescription drug coverage, you get a Part D, whether it's bundled in your Medicare Advantage plan or it's standalone by itself, PDP. So the issues when you think about risk solutions are these. Do you want to have networks and physician access? Do you want to see any doctor you want, or can you use a network to provide those healthcare systems for you? Do you want to have to get referrals to go see your doctor, or do you want to be